have Dr. Christopher Granger from Duke presenting Preventing Stroke and Atrial Fibrillation, Unrealized Opportunities. So Dr. Chris Granger is a professor of medicine in the Division of Cardiology at Duke University, and he's the immediate past director of the Cardiac Care Unit for the Duke University Medical Center. Dr. Granger is a fellow of the American College of Cardiology, the American Heart Association, and the European Society of Cardiology. He is associate editor at the European Heart Journal Cardiovascular Pharmacotherapy and on the editorial boards of several cardiology journals, including JACC and European Heart Journal. So pretty big journals. He is a cardiology section editor for Current Medical Diagnosis and Treatment. He is co-editor of the Fundamentals in Clinical Trials 5th edition textbook. He is past chairman of the American Heart Association Mission Lifeline Program and the American Heart Association Acute Cardiac Care Committee, as well as serving on the AHA Scientific Publications Committee. He's a member of the ACCF AHA STEMI Guideline Committee and the AHA ACC HRS Guideline for the Management of Ventricular Arrhythmias and Prevention of Sudden Cardiac Death. He has served on FDA advisory committees on an ad hoc basis. He has served for 10 years on the board of external experts of the NHLBI. His primary research interest is the conduct and methodology of large randomized clinical trials, I'm sure some of which we're going to hear today. He's co-authored more than 800 peer-reviewed manuscripts, and he currently serves on a number of clinical trial steering committees and data safety monitoring committees. He has coordinated the Duke Clinical Research Institute's activities and many clinical trials evaluating treatments of acute MI, heart failure, antithrombotic strategies in acute coronary syndrome, and of stroke prevention and atrial fibrillation. He's co-director of the reperfusion of acute MI in Carolina Emergency Department Project, North Carolina statewide programs to improve reperfusion care and AMI care for patients with cardiac arrest. Finally, he's the principal investigator of the Coordinate Diabetes Cluster Randomized Trial. He is co-PI of the Renal AF Trial, Quantum AF Trial, and the randomized trial and the Impact AF randomized trial, aiming to demonstrate how to improve use of anticoagulate for stroke prevention and atrial fibrillation, our topic here today. So please welcome Dr. Chris Granger, and thank you very much for coming and talking to us today.
Great. Well, thank you so much, Ben. And it's great to be here in Ottawa with Marino, and I have a number of collaborators and friends here, and so it's including Michelle LeMay and Peter Liu and others. And so it's fabulous to be here. And I would say the thing I'm most passionate about is simply generating and applying evidence to improve care of our patients. And it seems pretty simple, but it's not, right, Ben? It's like, and if you can integrate, if you can have a culture where you can integrate answering questions into daily care of patients, you're doing something really good and really important and really exciting. And I'm so impressed that you've done that, including with your house staff and your group here in such an impressive way. And I look forward to talking more about that. I'm going to talk about AFib, but a lot of these principles, I think, are also true for intensive care medicine, for cardiac arrest, for many other conditions where we have a lot of evidence where we know what we should be doing that we're not doing very well. And then we also have a lot of things where we're doing things where we simply don't know whether we should be doing it or not. So there's all these opportunities to improve care. Let's see. There we go. Okay, these are my disclosures, including for the topic of AFib. I've gotten funding. I've been involved with a lot of the trials of anticoagulation for stroke prevention in AFib, funded by industry. So I'll start out with this case. 90-year-old woman has paroxysmal AFib. Well, that already raised a question like is paroxysmal AFib have the same consequence as permanent AFib for stroke risk? And it turns out actually that it's a bit lower risk, but it's still high enough risk that once someone's been diagnosed with clinical AFib, they have high enough stroke risk where they're in the category of the evidence generation where there's the real benefit from anticoagulation. She's low body weight, has a bioprosthetic aortic valve. How about prosthetic valves? Is that okay to use DOACs for patients who have prosthetic valves? We'll get back to that. Turns out it is okay for bioprosthetic valves, is the bottom line. at least in the aortic position. Creatinine is one, but because of her age and weight, her creatinine clearance is actually quite low. That raises the whole issue when you're considering using a class of drugs that's renally eliminated. And we don't have much evidence for patients with more severe renal impairment. How do you address that? She falls. Now, this is the perfect audience to talk about falling. So I'm going to get back to this because it was the Ottawa study with Graham Nickel and colleagues in 1999 that showed that all too often we use history of falls as a reason to inappropriately withhold oral anticoagulation for AFib. That comes right from your group. She broke her hip when she was taking apixaban and broke her leg when she fell again a year or so later, also on apixaban. And she takes naproxen for knee arthritis. Now, I was talking with one of your pharmacists. So naproxen is interesting because it's a drug, at least for apixaban, where there's an interaction. So there's 40% more drug exposure with apixaban when someone's on naproxen. So there are two reasons to try to avoid non-steroidals for patients who are elderly and have AFib and are on anticoagulation. One, it increases risk of GI bleeding and renal impairment. And secondly, it has interaction with some of the drugs, including apixaban. So what should be done with this frail, elderly person who's obviously high risk for stroke, high risk for bleeding? So should you say she's just too high risk with these falls, stop the anticoagulation, switch to aspirin, which is kind of a nice, gentle treatment, switch to warfarin, where at least you can target the INR, continue apixaban, and she's on the 2.5 appropriately because she has 2 of the 3 dose reduction criteria: age greater than or equal to 80, body weight less than or equal to 60 kilograms, or creatinine greater than 1.5, which doesn't have that one, or place a left atrial appendage occluder device as an approach that would avoid the need for long-term anticoagulation. And I'll get back to her. And this is actually my mother. This is not a hypothetical case a few years ago. So I think the best single study now, this is a network meta-analysis done by one of our fellows at Duke that put together all the data in a patient-level meta-analysis from the 5 large trials, including Averroes, of warfarin versus DOACs, and then was able to analyze this in the most informative way. And there was this 20% reduction in stroke or systemic embolism, 11% reduction in mortality. This is important because mortality is actually more common than stroke in atrial fibrillation. So, and it's a kind of a nice integrated measure of the overall effect on stroke and intracranial hemorrhage and bleeding. So the fact there's a reduction in mortality, I think, is really important in terms of understanding what's the overall impact of DOACs versus warfarin for patients with AFib. But we also know that warfarin reduces mortality compared to control. So the benefit of anticoagulation in terms of mortality, I think, is quite important also. Major bleeding was somewhat lower, not statistically significant, but there was an interaction between which drug, which trial, and which drug, and the effect on bleeding. And then intracranial bleeding reduced by about 55%. So we have this. So if you put the DOAC versus warfarin on top of warfarin versus control, you get about 72% reduction in stroke with a DOAC versus an imputed control. So it's enormously beneficial for this population, the typical clinical AFib population. And yet, like so many things in medicine, it's used about half the time when we look at broad populations and carefully assess, like, is this patient somebody who would have been appropriate for anticoagulation? And they're only on it about half the time. And then this is just one of many studies trying to tease out, like, what are the factors associated with the lack of use of anticoagulation: older age, dementia, history of falls, were some of the factors. So why is it? And we've done a fair amount of work to try to figure this out. Like, but you could ask the same thing about statins. You could ask the same thing about blood pressure control. This is not unique to anticoagulation, but for anticoagulation, these were the reasons. This comes from the Orbit registry. But the theme was, it was risk of bleeding. That's the main reason. Prior bleeding, high bleeding risk features, frequent falls. So look at this. So of people over age 75, those who are not on an anticoagulant, 25% of the time that was reported to be because of falls or frailty. So that's a big deal to have people understand that that's not an appropriate reason. I'll get back to that. So we know these drugs are so effective. We know they're underused. So then the next question is what can we do about it? So we did this study. This is an implementation study, and I'm really interested now in like figuring out how can we better implement things. And it's not easy. And well, I'll tell you about this project, and then the next step is, okay, even when you do implementation study, then how do you disseminate that on a more broad scale? Is even harder, perhaps. So we took these were 5 friends around in low and middle income countries, and they each identified 10 centers, and then we randomized those centers to kind of a traditional implementation package. And what does that mean? That means you come up with a pathway about what you think is good care, and then you come up with a multifaceted intervention to address the barriers that you identify in your own environment. And then you measure what you're doing, because if you don't measure it, it's really hard to improve it. And then the other thing that seems to be important is to have a group come in from outside of your practice setting to kind of help, like a McKinsey consulting thing. Seems to be helpful for some reason in most of these studies of implementation. So we did those things, and we showed that we could have a 9% greater proportion of patients at the end of a year who had AFib and risk factors for stroke being on an anticoagulant. It was associated with a reduction in risk of stroke. But then, to me, this was actually one of the single most interesting things. Of those patients who were not on an anticoagulant, with a dedicated approach like this, about half the time we could get them on an anticoagulant. So that suggests to me that I think it's kind of a reasonable rough rule of thumb. Of these gaps in care, you can't close them all, because sometimes patients refuse, or sometimes they can't afford it, or there are legitimate reasons we just can't do it. But about half the time in this situation, we were able to get people on the appropriate treatment. This is one of the things we did. We simply said there were a lot of people who were just treated with aspirin because they were older and considered high risk. And now we know that aspirin is neither safe nor effective, especially in the older population. So we just said something simple. If you have a patient coming in on aspirin for stroke reduction for AFib, stop the aspirin and put them on an anticoagulant. And this is some of the data now with DOACs, at least with 2 of the DOACs, that I think is kind of interesting and probably not that well known. So here are 2 trials with 10,000 patients randomized, and they were randomized to aspirin or to either apixaban or dabigatran. Which group would you think had more intracranial hemorrhage, the ones on the DOAC or the ones on the aspirin? Numerically more. Presumably you'd think on the anticoagulant, but I wouldn't be asking the question if that was the answer, right? So here's the data. So Averroes, this interesting trial that a lot of people thought, this is another trial, a lot of people thought this was crazy. Like, who is it that's inappropriate for warfarin, but you put them on apixaban? But I think it was actually quite an important trial. And not surprisingly, in a typical AFib population, apixaban versus aspirin reduced stroke or systemic embolism by about 55%. But there was not a substantial increased risk of bleeding, modestly higher bleeding with apixaban. But the intracranial hemorrhage rate, there was 11 with apixaban and 13 with aspirin. It's the same. It's not less, but there's no substantial increase in intracranial hemorrhage in this population with apixaban versus aspirin. And then this is even more impressive. This is the RESPECT-ESUS trial. This was one of the 2 trials that ask the question, if you come in with a cryptogenic stroke, or probably a number of those strokes are because of unrecognized AFib or aortic thromboembolism or whatever. If you're on a DOAC, would that help reduce risk of recurrent stroke? So these are people with recent stroke put on an anticoagulant versus aspirin. And just with respect to this issue of intracranial hemorrhage, there was the same number, 32 with dabigatran, 32 with aspirin, in a group that's very high risk for intracranial hemorrhage. I'm not sure it's true with rivaroxaban. I think rivaroxaban's a little different. It may have a little higher risk of intracranial hemorrhage and certainly of bleeding, the way it's dosed at least. But at least for these two drugs, and I don't know, is dabigatran generic now in Canada? Yeah, and I think, dabigatran got a bad rap, right? It's renally eliminated. That makes it trickier. It's got a little more GI side effects, but it's a good drug, especially for reducing ischemic stroke. It's a good anticoagulant. And then the other theme is this, and this may be the single most important practical thing that I can tell you. And you all are probably already know this, but a lot of people don't. So let me just reinforce it. And that is, if you're on an anticoagulant for AFib, don't use aspirin in addition to that, even for patients who have coronary disease, with the exception of for the few months to a year after a stent or acute coronary syndrome. There you need to have an antiplatelet drug, we think at least. But for the general population, and this was there's several studies that suggested this, and then the FIRE trial. Now, this was a single trial in Japan with a little lower dose rivaroxaban than we use. 2,200 patients who had stable coronary disease. Most of them had had stenting or bypass surgery at least a year before they were enrolled. They were on rivaroxaban, and then they were randomized to either having rivaroxaban monotherapy or a single antiplatelet agent, either aspirin or clopidogrel. And not surprisingly, there was less bleeding, but it was a lot less bleeding, 70% less bleeding with monotherapy compared to having aspirin on board. But the surprising thing, there also was this substantially lower risk of thrombotic events with rivaroxaban alone than when you had rivaroxaban and an antiplatelet agent. How could that be? It's not fully explained. Part of this may be that if you have something that's got a lot more bleeding, when you bleed, you tend to stop the antithrombotic therapy and then you have events. But anyway, the bottom line is no benefit. I mean, in fact, harm both for thrombotic events and definitely for bleeding. And then the kicker was also this statistically significant, almost twice the likelihood of death. So stable coronary disease, don't use antiplatelet therapy. And this is now reflected in all the guidelines and the scientific statements as well. This was another more recent publication from the same data set not looking at time to first event, which is what we typically do in trials, because then we can use typical survival analysis techniques. But this is looking at something that we tend to do more now in clinical trials, total events. And then you see even more of almost a 40% lower risk of the composite outcome with DOAC alone versus DOAC plus antiplatelet therapy. And then this was another trial of about 4,500 patients, the Augustus trial. These are patients who'd recently had acute coronary syndrome and or stenting. And they were randomized to apixaban or warfarin, but the key thing here is the aspirin. So there's a double-blind study of 100 milligrams, 81 to 100 milligrams of aspirin versus placebo on top of the anticoagulant and clopidogrel. But nonetheless, the aspirin comparison, once again, we see about a 2-fold increased risk of bleeding, including intracranial hemorrhage, when adding aspirin on top of other anticoagulation and other antithrombotics. So aspirin is, it's not safe, right? Especially in the elderly population already on an antithrombotic therapy. And that's one of the key messages. How about intracranial hemorrhage? This is interesting data. I think this is from the Aristotle intracranial hemorrhage experience that Renato Lopez published. And one of the striking things was we tend to think that intracranial hemorrhage on warfarin is because we're overshooting the anticoagulation, but that's not the case. So this was a data set where every month we collected the INR centrally. And so we looked at patients who had intracranial hemorrhage when on warfarin. And almost 80% of the time, the prior INR was less than 3. So it's not usually a problem of over anticoagulation. It's that warfarin results in more intracranial hemorrhage than DOACs. And then we see aspirin here was an independent predictor. Being in Asia was also a powerful independent predictor, especially with warfarin. There's something about being in Asia. We're not sure whether it's Asian genetics and ancestry or whether it's the environment, but there is much higher risk of intracranial hemorrhage, especially on warfarin in Asia. How about the elderly? This was a nice recent trial from Japan, about 1,000 patients, all of them 80 or above, randomized to edoxaban or placebo. And there was a substantial reduction in risk of stroke and a modest increase in bleeding risk, but overall there was clear benefit from edoxaban in this older population. And then we've got a lot of evidence in the elderly from clinical trials. This is a little bit unusual. Usually the elderly are underrepresented, but because AFib is a condition of the elderly, we've got a lot of data, about 2,500 patients in Aristotle who are at least age 80. And we see that the benefits are, the relative benefits are entirely consistent. Therefore, the absolute benefits are even much greater in the elderly population. I think our oldest patient was 101 years old. I'm not sure we know about patients who are that old, but for most of the elderly, they get even greater benefit from DOAC and from DOAC compared to warfarin. And then the fall, this is that study from American Journal of Medicine or Archives of Internal Medicine in 1999, that with a Markov modeling, that first of all, in the elderly, falling is common, but falling resulting in head trauma and intracranial hemorrhage is not common. Now, if that's the case, then don't use an anticoagulant. Then you need to consider, left atrial appendage occlusion, or sometimes just bite the bullet, right? If somebody's got subdural hematomas from falling. But most of the elderly fall, that's not what's happening. And then they have clear benefit that outweighs risk, even for warfarin. So this calculation, probably this is an exaggeration, but it's pretty, but it makes the point that you have to fall 295 times a year before the risk outweighs the benefit from warfarin for AFib, stroke prevention. And then because DOACs, not only do they result in lower rate of intracranial hemorrhage, but lower rate of traumatic intracranial hemorrhage, then DOACs are even substantially more favorable than warfarin. And in fact, for example, we collected in Aristotle whether people had a fall within the last year. Of the people who had a fall within the last year, those that were assigned to apixaban, none had intracranial hemorrhage. Those were assigned to warfarin, 5 had intracranial hemorrhage. So small numbers, but consistent with the idea, much safer to use DOAC. And I'm a little biased towards apixaban. You can probably tell because I led the Aristotle trial, but I do think it's the DOAC that has the best safety profile in terms of the clinical trial data. So it's pretty simple about who we should be treating, who has clinical AFib, CHA2DS2-VASc of at least 2, but it's confusing because Greg Lip did this work that suggested that female sex should be a factor. And then when it was looked at more carefully, actually female sex is not an important independent factor. So we take that out of the CHA2DS2-VASc score. But if you're CHA2DS2-VASc of at least 2, then treat with a DOAC. If you're CHA2DS2-VASc 0, treat with no antithrombotic therapy and don't use aspirin at all for stroke prevention. Now, we still use aspirin, of course, for vascular disease. But then, as I mentioned earlier, then once the patient's on an anticoagulant, then stop the aspirin. But how about we got a lot of patients who are CHA2DS2-VASc of 1, right? They're if you've got a 70-year-old man who's got no other risk factors, or somebody who's 60 and has hypertension, we have a lot of patients like that. So what's a good tiebreaker? Well, first of all, shared decision making, right? Because some people, they just don't like the idea of being, they'd rather wait. Eventually, they're going to need to be on one, but they'd rather wait if they're concerned about taking drugs or bleeding. But then proBNP is a really powerful independent predictor. So this is something that I use. I look at left atrial size and NT-proBNP level as other factors that kind of help in the discussion about whether somebody's high enough risk to warrant anticoagulation. These are the data from Lars Valentin's group showing that CHA2DS2-VASc is an important predictor, and then NT-proBNP is important, and they're independent. They're they're additive. So if you're wondering, then NT-proBNP, and you see it's a continuous relationship, so there's no cutoff. But if somebody's NT-proBNP is 1,000, then that's a factor that you should take into account to say they're probably higher risk of stroke than you realize. And in fact, when you look at the multivariable modeling, the single most important factor is prior stroke or TIA. But if it's somebody who hadn't had a prior stroke or TIA, the single most important factor was NT-proBNP. And a single measure of NT-proBNP had more prognostic significance than the entire CHA2DS2-VASc score. It's interesting. And troponin, high sensitivity troponin, and then age, and then things like, I mentioned earlier, type of AFib. Once you take into these other factors into account, whether you have paroxysmal or permanent AFib was not an important factor. Then we also did the same thing with bleeding. And bleeding, there's this interesting biomarker called GDF15 that's the most powerful biomarker. It's not something I suspect you don't have it in Canada, or we don't have it in the US either, but it's also a biomarker that's important. With respect to bleeding, the most common site of bleeding and a type of bleeding that's not reduced with DOACs is GI bleeding. So this is a big deal, right? It's GI bleeding in this older population. And each of the DOACs, with the exception of apixaban, had more GI bleeding than warfarin. Also, low dose dabigatran, the 110 of dabigatran, had comparable rates of GI bleeding to warfarin. But if you have somebody who's high risk for GI bleeding, then use either apixaban or lower dose dabigatran as your go-to drugs. And then the other thing that's so important is just do things that reduce the risk of GI bleeding. The number one is avoiding aspirin or nonsteroidals. And the number two is proton pump inhibitors, let's say for someone with a history of prior GI bleeding. These are kind of simple things. Controlling blood pressure, that may reduce the risk of bleeding. So controlling blood pressure, there's nothing more important, right, for reducing death and cardiovascular disease and controlling blood pressure. So that's an important thing in the background. Procedures, if you're like us at Duke, there's still confusion about how often you need to hold a DOAC before procedures. And the bottom line is you probably don't need to hold it as long as you're doing, right? Like if you're going, I don't know what you do. Like if somebody's going to have radial access cath, what do you do? Just skip the morning dose?
They usually skip 2 days.
2 doses. 2 days? Yeah. So same with us. That's what the cath lab likes us to do. It's probably not necessary. Probably, we're probably holding it longer than we need to. Is it a big problem to hold it for a day? No. I mean, the risk of stroke is pretty darn small, but we probably don't need to be holding it as long as we do. The most common procedures are so common in this population of older patients. The most common was dental. The second most common was colonoscopy, and then lots of other things. I mean, the principle is pretty simple. It's just pharmacodynamics. So if somebody's low bleeding risk, then 12 to 24 hours, most of the effect of the anticoagulant is going to be gone in a half-life of 12 hours drug. And for high bleeding risk, 3 days, then it's essentially all gone. I mentioned chronic kidney disease being important. It's a risk factor for bleeding. It's a risk factor for stroke. The drugs are partially renally eliminated. And we don't have much data for patients who have more severe renal impairment. So it's an important area. And what we know with, at least with apixaban, and these are patients on this graphic that all got the 5 milligram twice a day dose. And even on the 5 milligram twice a day dose, the advantage over warfarin only gets greater as renal function decreases. It's really interesting. So you'd think renal impairment would be a bigger problem with DOACs that are renally eliminated, but in fact, it's a bigger problem with warfarin. Warfarin with renal impairment really increases the risk of bleeding. And part of the point here is if you only have one dose reduction factor, as your creatinine clearance gets down to 25 or 30, still use the 5 mg dose of apixaban. Because if you use less than that, you're not going to have the same stroke risk reduction. And you get this, it's really, compared to warfarin, it's actually still very safe. How about end-stage renal disease? We don't know what to do with end-stage renal disease. It's an area where we really need more clinical trials. I think it's a little different condition, AFib, in many patients who are on hemodialysis. Sometimes it's related to their electrolyte and volume shifts. It's much more paroxysmal than permanent. And we have no good quality evidence that anticoagulation of any type has greater benefit than risk. But knowing that there's a 72% reduction in stroke in the general AFib population, if you have someone on hemodialysis that looks like they're a typical AFib patient, they're a little bit older, they have high burden AFib, I think it's prudent to go ahead and anticoagulate them. I think even though a lot of people don't agree with me, I think it makes sense until we have better data, it makes sense to do it. And then the question is, okay, do you need to use warfarin or can you use a DOAC? And the one that's got the most evidence for a good profile is the one that's least renally eliminated, that being apixaban. And this is an example of an observational study, but I don't, I hope you can tell, I don't believe in observational studies. They tend to be just as likely to be misleading as clarifying, even with the best statistical analyses. We had this editorial, I like this, actually borrowed from Bernard Gersh. If you're not confused, you're not thinking clearly about anticoagulation and hemodialysis. But we did do, and it's just been, now it's in press, in circulation. We did this pilot study. It was only 150 patients who were on hemodialysis randomized to warfarin or apixaban. We looked at, the most important thing we probably did is look at the pharmacokinetics. And the bottom line is, you can probably be a little lower dose than you normally would in terms of the criteria, but basically use the same criteria. Still, most patients who are younger and who are reasonably high body weight, they should be on the 5 mg twice a day, even when they're on dialysis, to get the plasma concentration that's appropriate for apixaban. And these were the data. We looked at bleeding was our primary outcome. Bleeding rates were pretty similar between apixaban and warfarin when dosed that way. Okay, I'm going to spend a little bit of time on three interesting trials, I think. One of these is PROACT 10. These are to me, they were surprising results. PROACT 10A, this is a trial looking at re-asking the question that was so far informed just by the Realign trial, showing that for patients who have mechanical prosthetic valves that in that case, dabigatran had both higher rates of bleeding and thrombosis than warfarin. And this was looking at apixaban. And then the NOAA trial that was looking at patients who have subclinical AFib detected by devices, but not diagnosed clinically. What should you do with anticoagulation with them? And then finally, the Invictus trial, which I think is an interesting trial. So Invictus, looking at this question, there are these two major categories of patients, right, where we say you still need to use warfarin. Patients with rheumatic mitral stenosis, moderate or severe mitral stenosis, and patients with mechanical valves, and maybe patients with end-stage renal disease. I already covered that. So rheumatic heart disease is common. Part of the reason we don't have confidence for DOACs was because they were excluded from the major trials of DOACs versus warfarin for AFib. And the reason for that was because they weren't included in the original warfarin versus control trials. So the FDA said you can't include them in the non-inferiority calculation because they weren't included in that data set. And the reason they weren't included is the typical mitral stenosis AFib patient has a big calcified left atrium and very high risk for stroke. And so they were thought to be unethical not to anticoagulate because they're so high risk for stroke. So Invictus, led by the McMaster group, randomized patients in mostly low and middle income countries, 4,500 patients, average of 3 years, pretty good follow-up, stopped early by the DSMB. And here were the main results for stroke, systemic embolism, MI, or death, which that endpoint was changed during the trial because of low event rates. And what you see is that there was this increased risk with rivaroxaban versus vitamin K antagonists, but there were some statistical challenges because early on there was no difference. In fact, the point estimate was you did better with rivaroxaban for about a year, and then it's flipped, and then you did better with vitamin K antagonists. That creates a challenge in terms of the proportional hazards assumption for the typical survival analysis. But if you look at the actual numbers, so mortality was 25% higher with rivaroxaban, stroke was 50% higher, but relatively low rates. Major bleeding was comparable. Intracranial hemorrhage was a little lower with DOAC, not surprisingly. So there's some really interesting issues, though. The primary results, I'll just start out by saying I think they're clear, and we should be using warfarin for patients with rheumatic atrial fibrillation. Anytime a trial is stopped early by a data monitoring committee, you need to think it may be a little bit of an extreme finding, because trials tend to get stopped when maybe the separation is the greatest for either benefit or risk. The outcome was changed during the trial. The curves didn't separate till about 3 years. Vitamin K treatment was extraordinarily good. Like the time in therapeutic range was like over 60%, which is really strange in these low and middle income countries where usually warfarin is so hard to give. And then the reduction was in mortality. And it was not due to deaths that you would thought would be modifiable by an anticoagulant. Half of these patients were not on an anticoagulant before enrollment, and maybe patients who were lower risk were selected out because even though they weren't on an anticoagulant, very few of them had had prior stroke. Some of them didn't even have mitral stenosis; they just had a history of prior rheumatic disease. And like I said, the adherence and the persistence on anticoagulation was extraordinarily good with vitamin K antagonists. TTR I mentioned, and it's a different population. They were much lower risk for stroke than you would have thought with a rheumatic AFib population. So here's Invictus compared to the other DOAC versus warfarin trials, much younger, much more likely female, much less hypertension and vascular disease. So, and then here's the stroke rates were quite low, and the mortality rate was pretty high. And the biggest effect on the outcome was in terms of the absolute benefit was on reducing mortality. And then this is interesting. If you look at the total difference in deaths, the entire difference was explained by a decrease in sudden death and pump failure death. I don't know how warfarin reduces sudden cardiac death compared to rivaroxaban. But anyway, that the results are there. I just think when you see a result that's surprising, when things don't really fit together, I'm a little bit less confident that the results are totally definitive, but I'm not suggesting, I mean, it's a good trial. It's a big trial. It means we should be using warfarin for this population, but there are those interesting questions. How about mechanical heart valves? Might it be okay to use apixaban with a low profile aortic mechanical valve? We thought so. I mean, I thought this trial was going to be positive. This is a trial John Alexander from our group led 1,000 patients with the Onyx valve. They even excluded the first 3 months, which is where much of the risk in the Realign trial was early bleeding, early thrombosis. So they waited 3 months and then they randomized to apixaban versus warfarin. And even then, we don't know the results yet. It was just stopped like 2 weeks ago. But even then, the reports from the investigators and the DSMB was that there was higher stroke rate with apixaban than warfarin in this population. So I'm afraid we're stuck with warfarin for mechanical valves. How about this issue of subclinical AFib? So this, again, the McMaster group has done some good work with this, with the ASSERT trial, and this is an area of a lot of interest, because especially now with wearables, we're detecting all this AFib. If you're like me, you have a fair number of people come into your clinic saying, I've got this alert. I didn't even ask for it, but I got this alert. Now what do I do that I may have AFib? I mentioned the RESPECT ESIS trial. This was the trial of patients with cryptogenic stroke. And the reason this is relevant is because some proportion of these have low burden AFib. It's just not been diagnosed, of these people that come in with cryptogenic stroke. Even when you do your monitoring in the hospital and maybe a 2-week Zio patch or whatever, and you see no AFib, some of them have AFib. The results of this trial were interesting. This is another one where the proportional hazards was not met. The overall outcome was what was the rate of recurrent stroke with aspirin versus dabigatran was not, there was no significant difference. But if you do an analysis with a landmark technique looking after a year or so, then there was real benefit from dabigatran. So part of the question there was, is the reason for this late effect that these patients are developing AFib over time, and then maybe it's good to be on an anticoagulant? So we looked at that and said, okay, what are the predictors of AFib? And it's possible this is the case, but this is just hypothesis generation. But once again, we see this proBNP was the single most important predictor of who's going to develop AFib. And the other two independent predictors was hypertension and older age. So those are factors that might make you, I think the message here is, someone comes in with a cryptogenic stroke and you don't find anything. If they have some of these factors, monitor more carefully for whether they develop AFib in the future, because a lot of these people will develop AFib and then they should be on an anticoagulant. And then we have these different techniques. We have a LiveCore. This was invented by a previous Duke Medical School graduate. It's a pretty nice device. Now there's actually just a card that you can put in your wallet, like a credit card, that can actually generate the rhythm strips. And then the Apple Watch, the Apple Heart Study looked at this question. So here's another question for you. If a patient comes in to your clinic saying their Apple Watch beeped at them, saying that it was an alert that they had AFib or possible AFib, what's the likelihood they actually had it? What do you think? It's 12%, 52%, or 84%? AFib. So it uses this algorithm. The reason it's pretty good is this: it uses an algorithm where you have to have 5 out of 6 of these 1-minute tachograms showing substantial irregularity. This is from photoplethysmography. This isn't from the rhythm strip itself. So this is just the rate, just the irregularity of the rate. But if you have those 5 out of 6, it's pretty likely that you've had AFib. Here's the data. So the number of alerts, 3% of those who are at least age 65, and then they had a patch put on. Of those that had an alert, when they had a patch put on for 2 weeks, about a third had AFib on the patch. But then when the patch was on and they had an alert, then 84% of the time they actually had AFib during that alert. So but the problem is, that's not really what your question is. If they have a couple of minutes of AFib, it probably is irrelevant in terms of how you should be treating them, other than to know they're more likely in the future to develop more persistent AFib. So it still doesn't help us that much. And then this is the Fitbit study, really very similar results, which makes me convinced these data are probably pretty reliable. About 3%, 3 to 4% over 65 had an alert that went off. 32% of the time, if they had an alert, it was on a subsequent patch, they had AFib. And then even higher percent, when the alert goes off, they really have some AFib. And then this is important. So this is the ones that had a patch on and had AFib. So these are the ones that had an alert and then had the patch on. about half the time it was at least 6 hours. They even had a fair number that were over 24 hours. If it's over 24 hours, that's where I think most of us agree. If it's over 24 hours, probably that's pretty similar to clinical AFib and you should anticoagulate. Less than 24 hours is a lot of uncertainty. And I mentioned this, but this NOAA trial, this was 3,400 patients who had these atrial high rate episodes. Usually that's AFib. They had to be at least 65 with at least one additional risk factor for stroke. And they were randomized to edoxaban or usual care. And this trial was just stopped in September with one of their people having this quote. We don't know the results yet, but this quote is kind of interesting that NOAA was designed to find out whether NOAA can reduce the stroke rate significantly in this subclinical AFib device detected AFib population. And he says, based on the preliminary results of NOAA, we are already sure that it is not the case. So this suggests that, this suggests to me there was probably no reduction at all in stroke with edoxaban versus usual care, but we'll see what the results are. And then Artesia trial, which is a little bit of a larger trial, 4,000 patients, apixaban versus aspirin is ongoing. But I'm suspecting now that if you have somebody who's got these alerts from their watch and they have got low burden AFib, and even if they have risk factors for stroke, I don't know if that population is a group that's going to have benefit from anticoagulation. I think they're going to have, I would suspect it's going to be more like 12 hours of AFib episodes per day before they have enough AFib in this population to really warrant anticoagulation, but we'll see. So Rich Whitlock did this fascinating study of this LAOS 3 study, asking the question, if you have cardiac surgery and you had AFib, do you benefit from left atrial appendage exclusion? Even for patients on anticoagulation, there was this 30% lower rate of stroke. It's really, and this has really changed practice, right? This is a great trial because now this is routine. I think it should be done in every surgery patient who has AFib. And now the question, and I believe that, and I don't know if this is confidential or not, but I believe that this will go forward, is a trial of watchmen, of patients who have AFib and they're high risk for stroke, and they're on an anticoagulant, then randomized to left atrial appendage occlusion percutaneously versus control. Because if we can reduce the risk by another 30% in someone who's got a high enough risk for stroke while on an anticoagulant, that would be really important. So that's another interesting area. So finally, another area of a lot of interest is the factor 11 inhibitors. And we've seen this so many times over the years, looking for the holy grail. You can tell I'm a little bit skeptical. I think we need the data before we see how big of an effect this is going to have. Jeff Weitz and others have kind of come up with this paradigm where if you uncouple the factor 11 in the extrinsic pathway from the keeping intact the intrinsic pathway, maybe you can uncouple physiologic hemostasis from pathologic thrombosis. So therefore, factor 11 inhibition might be a way to keep people able to blood clot when they need to prevent bleeding, but prevent stroke and thromboembolism. I would say the data so far suggests that even when you inhibit factor 11 to a high degree, it does seem as though it's pretty safe. I thought it'd be hard to be safer than apixaban, but based on the Pacific AF trial, it looks like this wasn't major bleeding. I don't think any patient had major bleeding in this whole trial of 700 patients, but there seemed to be less clinically relevant non-major bleeding with factor 11 inhibition than with apixaban. So I'll just come back to my mother then as my final slide, and just to highlight the fact that especially the patients who are frail and high risk for bleeding that we really can do a better job in their management. I think we have a lot of information about how we can do that. Generally, it's being on a DOAC. But I do think left atrial appendage is another, occlusion is another option, perhaps factor 11 inhibition, but we got a long ways to go before we'll generate the data on that. And then there's lots of unanswered questions that we need to address around renal failure and subclinical AFib and AFib that occurs in intensive care units, right? Like 20 or 30% of people, if you look carefully, have some AFib, and post-surgical AFib. We've got lots of these questions out there to better understand this condition and how to improve outcomes. So thanks for your attention. I'll stop there and happy to answer questions.
So I'm just going to remind people that are online to use the question box if you have any questions, or raise your hand and we can unmute you. I'm just going to start and say I disagree with what you did there. I would randomize your mom in Catalyst, which is a randomized clinical trial we're doing here at the Heart Institute of DOAC versus left atrial appendage occluder. So you have patients that have atrial fibrillation and are interested in a non-pharmacologic approach. We're always looking for patients, and we're currently randomizing them. But thank you very much for that great talk, very scoping, obviously highlighted a lot of the clinical conundrums which we have. So I'm going to open the floor and start with people here and people online. Are there any questions? Dr. Bolian. Oh, sorry.
Or I can repeat it if you want. Yeah.
So the two patient populations that find sometimes difficult to decide what to do. One of them is you're already on an anticoagulant with a stroke. There's a background of risk of never stroke that would happen. Do you continue on the same anticoagulant?
So what if somebody has a stroke and they're on an anticoagulant? So great question. And the short answer is we don't know. You have to use your best clinical judgment. I will say the first thing to do is make sure they're being adherent, right? Because maybe they missed some doses, so you want to know that. Secondly, was there some strange thing like are they on an anti-seizure drug which would promote metabolism of the drug and maybe make the level lower? So ask those questions. But we also know that there are a lot of strokes that are not caused by the AFib itself. So the fact that somebody has a stroke, so maybe it depends on the workup for the stroke. Was there another cause of it that you wouldn't think would be modified by the anticoagulant? That would help you. But in the end, we're not preventing 100%. And so I wouldn't necessarily change the treatment. But it's interesting you ask. I'm struggling this right now. One of my best friends had recently was on apixaban and had some double vision for 45 minutes that thought might be a TIA. And he'd had a prior TIA even before having diagnosis of AFib. And the question is, should he be put on clopidogrel in addition to the apixaban? It's the same general question. And for him, I said, no, it's, we know the risk. We don't know the benefit. We know there would be substantially higher risk for that. So don't do that. But I think it's a good question. I think it's reasonable to change. Like, let's say it's somebody who's younger person, low risk of bleeding, they're on apixaban and they have a small stroke that you think may well have been from their AFib. Then I would go with dabigatran. That's our most effective drug to prevent ischemic stroke.
And the second part is the other side in terms of cryptogenic.
The Navigate-ESIS trial, there was no benefit from rivaroxaban. The Respect-ESIS, as I showed you, there's a little bit of, there's a suggestion of at least no harm, maybe a little bit of benefit from dabigatran in the patients with cryptogenic stroke where you're worried about AFib and you just haven't diagnosed it. So I don't think it's crazy to do that. I do think an ILR is a good thing to do. I think if you're having very low burden AFib, I'm not sure that's that important. I don't know. So once again, some uncertainty there, but do check their pro-BNP and left atrial size. And if they're older, then at least be very vigilant to monitor if they develop more substantial burden of AFib. Yeah, good question. I think, this is like, on average, we enrolled patients pretty soon, like within several days, a week after their stroke. So I think even right away is okay to check the pro-BNP.
So sorry, that last question for the people online was about what to do with embolic strokes of unclear source and DOAC. So I'm going to just switch to some of the online questions, and then we'll come back here. So Dr. David Burney, who is our chief of cardiology, said, you briefly mentioned LAO devices. Do you often recommend these devices in your patients currently?
Yeah, I mean, as I said, I think that the most exciting trial by far in the field was LAOS 3, right? It was really impressive. So that's changed my opinion about left atrial appendage occlusion. And the devices are getting better. They're safer. I think they're more effective. So I think it's a really, I think for patients, for that portion of patients who really either have had, like, let's say, recurrent GI bleeding. That's probably the number one bleeding, most common type of bleeding that would say this patient can't be on an anticoagulant. Or the patients who just refuse, right? We have a lot of patients who just refuse, even after explaining everything to them. Then I think left atrial appendage occlusion, I think it does reduce stroke. I don't think it reduces it as much as a DOAC, but it reduces it, I think, substantially. Therefore, I think it's a really important part of our toolkit.
Yeah, I mean, we do a fair amount of left atrial appendage occlusion here. I couldn't agree with you more. I think there's certainly a niche for it. And I think the trials like Catalyst and the Watchman trial that are going to be coming out soon are going to really give us our first look at DOACs compared to left atrial appendage occlusion. And I agree with you. When LAOS came out, I thought that trial was going to be negative because they continued the anticoagulation. So, the concept of mechanical obstruction in addition to anticoagulation, I just didn't think there would be enough effect size to be able to demonstrate efficacy. And I've had some good talks with David Holmes about combined, should the strategy be that we mechanically obstruct and add an anticoagulant to a regimen for even further benefit? So many great questions to ask. Anything else here in the audience? Yeah, Juan, there, I'm going to pass you the mic.
I'm just interested about the focus on BNP as a predictor of strokes in patients on atrial fibrillation. I've had a number of patients who are CHADS 0, let's say, and wouldn't necessarily have an indication. So I wonder why there isn't more of a move towards introducing BNP as an additional risk factor, particularly for patients who don't have heart failure. And then the other thing is, on previous occasions, I've found that the definition of heart failure in the CHAD score is not always clear.
Yeah.
So there are patients, for example, that may have a low normal ejection fraction, but have never had clinical congestive heart failure. And in those patients, I wonder what you recommend in terms of anticoagulation, whether a BNP would be informative.
Yeah, good question. Good question. And another thing is left ventricular thrombus, right? That's another whole topic. And there was a really nice scientific statement from the American Heart Association, put together all the data on LV thrombus and its management, which kind of overlaps in some of the heart failure data. So the reason pro-BNP isn't integrated is because we have relatively limited data, right? So from big population studies. But I do think, based on the data that I've shown you, I think it's a really important risk factor, at least as a tiebreaker, as you're suggesting. Of course, it does interface with heart failure. And then we have trials like the Commander trial where low dose rivaroxaban, I thought that clearly would have been positive based on COMPASS, that in the heart failure population, COMPASS had this great benefit on stroke reduction with low dose rivaroxaban and aspirin. And then in Commander, which tested the same thing in a heart failure population, there was no benefit. It's like that sometimes the trials make us a little bit humble about, how much we really know. So but I also totally agree with you that the heart failure definition in the CHAD score is pretty wishy-washy, right? Usually it's an EF less than 40% and or clinical heart failure. So it's, I mean, it's, you know, the whole intersection of heart failure and AFib is another important area, like who should have ablation, you know, how should we manage AFib in that population? But we know once you get advanced heart failure and these patients who come in shock to our intensive care units, like half of them have AFib. It's such a common condition. And so both managing the AFib and the stroke reduction strategies for that population are all important topics.
Perfect. So I'm going to go back online to Dr. Peter Liu, who's our Chief Scientific Officer. So he writes, patients who've had bleeds on DOACs have a particularly high risk of mortality, but this may be due to stopping DOACs and never restarting going forward. What is your approach to restart patients back onto a DOAC after a bleed?
So Peter, thanks, and great to be visiting. So thanks for the great job you're doing here in this great group that you're leading. So it's a really important topic. It's another very important topic because, not surprisingly, all too often, as Peter's suggesting, we don't restart the anticoagulation. Like something like 20% of the time, it never gets restarted after, let's say someone comes in with a GI bleed with a treatable cause of it. There was another study from Ottawa from the same group. I think also Graham Nicol was involved with it also a while ago, about the same issue about anticoagulation and GI bleeding that actually addressed this. And it suggested that for most of these patients, even with GI bleeding, they should be resumed. And what we've said is, like, you know, who knows when, but I think on average, like 1 to 2 weeks after hemostasis after a GI bleed, especially if one thinks one's either taken away a factor that contributed or treated the cause. It's a little harder if it's AVMs or something like that, right, where you can't really treat the underlying cause. But for most of these patients, start a week or two after. Even for patients who have intracranial hemorrhage, we think most of those patients within 1 to 3 months after an intracranial hemorrhage, many of them can be carefully resumed on a DOAC.
I find the intersection of bleeding and thrombosis very difficult to navigate clinically. Some of that mortality is undoubtedly going to be due to competing risk, right? The reason you bleed is the reason that unfortunately you pass. But even when you adjust for those in observational data, these patients do much, much worse. And everyone likes to say it's not resuming the medications, which might in part be it, but there seems to be other factors there, whether the bleeding event itself, the transfusion, the hospitalization, the loss of functional status in frail, vulnerable patient populations. Bleeding is bad. This isn't just atrial fibrillation. This holds true in our coronary artery disease. And this is where I think bleeding reduction strategies like left atrial appendage occlusion, dose reduction are super important. So we have a question from Carol Middleton. So she writes, how much does the patient's activity affect the risk of stroke and management?
How much
does the patient's activity affect the risk of stroke and management? So I think she's asking.
So like, how important is exercise as part of a strategy to kind of manage these patients and improve their overall health? Is that kind of what? I mean, I think that's really important, right? But it's actually an important question and something worth reiterating. Like, we now have I don't know if you guys use this. I use this with my patients, like the American Heart Association Life's Essential 8. It's like the 8 things you can do to improve your cardiovascular health. It's all the simple things like exercise and diet and avoiding smoking and losing weight, all those things. And I think it's extremely important to have kind of to treat the risk factors and treat the comorbidities in this older population with AFib as a way to improve their health and their functional status. We didn't spend much. There's so many topics, right? But the role of ablation, I think, I was also somewhat of a skeptic about ablation for more than symptom control, but I'm becoming more convinced that early ablation for many of our patients with AFib also improves outcome.
I think the question was getting at, kind of that, like you alluded to there, that multifaceted approach to stroke prevention. Obviously the focus of the talk was on how to optimize anticoagulation and these clinical scenarios where the answer might not be so clear. But yeah, super important to evaluate the patient as a whole, make sure that you're addressing all of their risk factors, smoking, blood pressure, making sure that they're exercising regularly and eating healthy. Any other questions locally? Otherwise, we got one more from Dr. Liu online. Perfect. Yeah.
Hi, I'm Tammy, one of the pharmacists here at the Heart Institute. You mentioned the drug interaction between anti-epileptics and DOACs, which is a significant one. How do you manage those patients? Do you put them on warfarin?
Sorry, would I use, was the question, would I use warfarin in that situation? Well, I mean, drug interactions are really important for these drugs, right? And some of the common ones are, are like amiodarone and diltiazem, and there's lots of issues with drug interactions. Most of the interactions are only like about a 50% increase in drug exposure, and usually we don't think that's a big enough effect that it should change what we're doing. Sometimes if somebody's right on the margin, let's say they're 79 years old and have a creatinine of 1.8, then I would use that to like modify my dose reduction, let's say for apixaban, if they had that. Be pretty rare that I would go with warfarin. The only examples maybe are, some of the patients who are on like anti-seizure drugs where they're big effects, and at least with warfarin, you can follow the INR. We rarely do drug monitoring for like DOACs, but sometimes you can check a chromogenic 10A assay with the standard of the DOAC to make sure they're having your anticipated plasma concentration of the DOAC. This is where I call my pharmacy friends.
Right, one more question. Here you go.
Just making sure I understood the data, particularly in end-stage renal disease patients. So you're showing how even apixaban, for example, compared to warfarin, did not have an excess risk of bleeding and potentially reduce ischemic outcomes. So in that patient population that we see pretty frequently, would you suggest that we use apixaban or a DOAC as opposed to warfarin or nothing in that patient population?
Yeah, I mean, maybe that's a great final question, because what I'm going to tell you is we need more randomized data. I don't have much confidence to recommend anything with, but I do think we now have enough data that it's probably reasonable to try apixaban versus, rather than warfarin for the patients on hemodialysis. But again, I don't know who we should treat, and I don't know how much benefit there might be of apixaban over warfarin in that population.
It's a difficult clinical conundrum. I tend to close their left atrial appendages because if you meet me, that's what happens to you. But
I think that's a great point. And that would be a great trial. We need that trial.
Yeah, so
we need a trial.
The problem with and this is a great learning point for the trainees. So I know Hamilton was looking at doing that trial for a while, and the problem is competing risk. When you look at patients on hemodialysis, their mode of death is coronary artery disease. And they have a very short life expectancy. And so it becomes very difficult to do clinical trials. And I agree with you. I think, there's enough of these patients. We should be able to look at a trial, at least with a composite outcome, to see whether it's a net benefit. But yeah, in the interim, we're in the lurch, and I see a lot of patients on apixaban. That practice has been widely adopted here in Ottawa. I think mechanical obstruction with the left atrial appendage occluder is reasonable, but I couldn't agree with you more. I mean, man, these patients are here 3 times a week. We should be able to get them into clinical trials, monitor them closely, and figure out whether or not we're doing the right thing. I think I'm going to end it there just because we're running over time, and I know people have to get to their clinical duties. Thank you very much again for your wonderful talk and taking the time to visit with us.
Thanks.